Hi and welcome back. Chronic pain after spinal surgery can be devastating for you and those around you, particularly if you've expected to be improved following the surgery and you're not, or you're worse off. As a pain specialist physician with more than 20 years experience, along with this clinic that has treated now more than 22,000 patients since its inception almost a decade ago, we know a thing or two about managing chronic pain, notably chronic pain after surgery, notably chronic pain after spinal surgery. I'd like to talk to you today about treatment options available for those suffering with chronic pain after spinal surgery. So let's dive in. Previously, I've discussed chronic pain after surgery, the prevalence of this problem, and why it's occurring. I've also discussed the prevalence of chronic pain after spinal surgery and why it occurs, and that's important. There'll be some links to the videos below. If you understand why you're in pain, then you can provide the appropriate treatment. Now, whatever anyone says to you, there is no one-size-fits-all treatment for chronic pain after spinal surgery. But there are some very important principles to go through, and that's what I'd like to talk to you about. I'm going to use a paper as a reference. This paper doesn't have it all. It's an open access paper, so have a look at it for yourself because knowledge is power, particularly if you've got chronic pain. The paper is called Chronic Pain After Spine Surgery, Insights into Pathogenesis, Causes, and New Treatments and Prevention Therapies, but we're going to discuss new treatments, and this paper will just be a rough guide. There are two ways of looking at pain management for such a person. One, you've got to look at the person as a whole being, separate to the pain. And then number two, you've got to look at the pain. And then, of course, you've got to consider both entities, so the person and the pain. So let's talk about the pain first. I'll get to the person later. The pain part of the problem. You've got to understand where the pain is coming from, and that's why an experienced pain physician working with a good spinal surgeon or a neurosurgeon can piece together the pieces of the puzzle and work out what is going on and what needs to be done about it. We work with a number of incredibly well-regarded surgeons, specialists in their field, and so it's important to get somebody else, sometimes an external view of your situation, of your scans, because there are some things that require attention. Now, if you've got pain after spinal surgery, particularly if it's early after the spinal surgery, it is very important to work with your spinal surgeon, whether it be a primary surgeon or for a second or even a third opinion, to make sure there is nothing going on that requires reoperation. It's a terrible thing to think about, but it's very important to consider. If it's immediately postoperative, is there a hematoma? Is there a fracture? Is there a problem with this screw going into the wrong position? It's important to make sure in the immediate postoperative period that there's nothing surgical happening that requires reintervention. But if we're talking months or longer down the line, your surgeon has probably done that already and assessed the situation. But nevertheless, it's sometimes not a bad idea to assess that situation again. And there are four big structural factors that need to be considered early on. Number one, is there a recurrent disc herniation? So has a disc prolapsed at the same level above or below or somewhere else? Number two, is there spinal imbalance? So has the surgery led to some kind of imbalance, either above the surgery, below the surgery, at the surgical site? So there's been a knock-on effect from the surgery itself. Number three, is there any spinal instability? Has the surgery made the spine unstable in some way? Number four, is there a pseudoarthrosis? And that's where the surgery, the fusion, has not happened. And so you've got these micro movements, if you want to look at it that way, that requires assessment and re-intervention. So those are the big four things that must be considered early on in terms of managing pain, which is a symptom of a complication. But then if that's all been done and you're left with this new, lingering, worse pain, it needs to be assessed in great detail. And there are many things that can be assessed. So let's look at other factors in terms of pain management. And there are two big ways of looking at pain management, or two big options for pain management. One is medications. And there are many medications that can be considered. Medications have pros, medications have cons. You need somebody to balance that out, assess both. Simple medications like anti-inflammatories, like paracetamol, have been studied. And whilst they're mild, I don't believe they can do very much in these situations with severe neuropathic pain. Other medications like anticonvulsants can be used. Other medications like tricyclics can be used. Medications like SNRI, I know it's a mouthful, serotonin noradrenaline reuptake inhibitors, can be used, all to manage nerve hypersensitivity, neuropathic pain. There are many supplements that can be used. PEA, alpha lipoic acid. Sometimes we use even stronger medications like ketamine infusions, lidocaine infusions, to manage the pain. So cautious use of medications can suppress pain and pain signals and pain hyperexcitability. Opioids can be considered as well, and that's a different discussion. There are pros and there are cons, and studies have shown that opioids can work in the short term, but in the long term there may be significant risk factors, and it depends on the person sitting in front of me where we make that decision. An opioid in somebody that's 80 years old following a spinal surgery, or 70 years old following a spinal surgery, is a different discussion to have than somebody that's 33 years old and had a spinal surgery. So medications are one aspect. The second part of managing the pain, we've talked about medications. The second part is using interventions, and there are a few types of interventions. One is simple nerve blocks, simple joint blocks. So for example, if the sacroiliac joint below an L5-S1 fusion is painful, a local anesthetic, a steroid injection into the sacroiliac joint can reduce pain. If it's a similar factor to joints above the fusion, so that's called adjacent segment disease, that can be treated with a nerve block or a radiofrequency of the facet joints. If it's pure inflammation around the area, around nerves that are inflamed and hypersensitive, then local anesthetic steroid injections can help. If we think there's adhesion, scar tissue around a nerve, we can use an adhesiolysis technique, which is where we use medications to free up scar tissue, just injected medications, and that can help treat pain that is caused by inflammation and scarring. So injections, simple injections, can help diagnose and help treat. Is it pain above the fusion? Is it pain below the fusion or the surgery? Are the nerves inflamed? Those are the kinds of approaches. Is it the joints above, the joints below, and the joints nearby? Another type of intervention is called neuromodulation. So using targeted treatment. So not just giving you medications that go everywhere and treat pain and give side effects in some instances, but using treatment targeted on the desired site. So things like spinal cord stimulation can be utilized to treat refractory neuropathic pain in a person, which is the second aspect, which I haven't come to yet, that is in quite a good state, physically, psychologically, and not on too many medications as well. So spinal cord stimulation, neuromodulation, electrical stimulation can absolutely be used in some instances with refractory pain. It has been studied. The studies are fairly good. It is better than conservative management. It just is. There have been some reports about spinal cord stimulation that have had poor outcomes. And like anything in medicine and anything in this world, what we use has got to be used by the right people, for the right reasons, on the right patient, for the right pain. There are many rights that you need to get in order before a treatment like this, which is what we call an advanced pain treatment, to be helpful. So it's something you just don't throw around. You use it cautiously and you use it in appropriately selected people. And if you do that and you're good at it, it can be life-changing. And I'm unable to share testimonials because we are unable to do so in places like Australia, but there are good stories out there. I ask you to talk to your pain physician, put in touch with patients that are doing well, whether it be from an injection, a radiofrequency, a nerve ablation, even neuromodulation. Another form of neuromodulation is targeted drug delivery. We call it intrathecal drug delivery. And that's where medication like morphine and or local anesthetics can be delivered directly into the spinal fluid where the pain occurs. And that is, again, an advanced pain therapy. There are pros, there are cons, but if you have the right pain, the right patient, the right circumstance, and you've eliminated or reduced risk, this can be life-changing. So another form of pain management, pain intervention. Clearly, surgery is another pain intervention as well, which we've discussed right at the beginning. But of course, reoperation, further surgery is an option, but it's got to be balanced out with potential pros, potential cons. Surgery is traumatic, no question about it. So we've discussed some pain reduction options, medications, interventions, and advanced pain therapies. But again, it depends on the cause. And there are many causes which I've discussed in the previous video. What about assessing the patient? And that's the second big aspect to managing pain in this situation. You've got to assess the patient, because the patient, there may be some factors that need addressing. So what factors am I talking about? Well, there may be some physical factors. Stress is a factor that absolutely affects patients' recovery from pain. And we're all stressed to varying degrees. So mindfulness-based stress reduction techniques, physical therapy techniques are an absolute must. If you've had surgery, it hurts. You don't move. You get stiff. You get weak. You get into this vicious loop. It is safe to move your body. It is important to move your body, and it can sometimes take training to move your body after you've had pain, particularly for a long period of time. So movement is important. Psychological health is important. Stress management is important. And of course, you're going to say, I need the pain controlled so I can do those things, but it doesn't always work that way. You need to have these things happening concurrently, side by side, managing the pain, trying medications, trialing other forms of advanced pain therapies, managing the person as well. They've got to go hand in hand. It don't work in a silo approach. So looking at the person, still focused on the person. Smoking can have an impact on pain. Excessive alcohol can have an impact on pain. Excessive weight can have an impact on pain. What we put into our bodies in terms of diet can have an impact on pain. Why are we talking about reoperating? Why are we talking about all these advanced therapies or medications with side effects when you can change some simple factors in life that may have an impact on your well-being and your pain? That's why there is no one-size-fits-all treatment for managing pain after spinal surgery. That's why this is such a complex pain condition. It requires people with expertise. It requires people with experience. It requires people with all these techniques and approaches at their disposal so that it can apply to the right person at the right time of that pain journey.